The American Brain Tumor Association is pleased to welcome you back to our webinar series. My name is Umbreen Maan, Program Manager at the ABTA, and I'm delighted to introduce today's topic, How Metastatic Brain Tumors Affect Your Kidney Cancer Care. Thank you to today's webinar sponsor, Genentech, for their support of this program. Today's webinar will provide you with an overview of kidney cancer brain metastases, how it progresses, signs and symptoms to be aware of, treatment options, as well as a behind-the-scenes look of how a brain mets tumor board works, and insight into the lived experiences of brain metastases patients and families. This webinar is presented in partnership with the Kidney Cancer Association. Without their support, this program would not be possible. We are honored to have Amy Marbo here with us today, Director of Patient Programs at the Kidney Cancer Association, to share a little bit more about their incredible mission and programs. Thank you so much, Amy, for being here. I'll go ahead and turn it over to you.
Well, thanks, Ambreen, and we are so happy to be partnering with ABTA on this webinar, and a very special thank you to the physicians and our patient and caregiver speakers who you'll all be hearing from later. Next slide. A little brief overview about the Kidney Cancer Association. We were founded in 1990 by a small group of patients and doctors in the Chicago area, and we have grown into a large international nonprofit organization. We really pride ourselves on our 4 mission pillars: support and empower, research, educate, and advocate. Next slide. Our patient services programs are robust and vast. We have so many, and I don't have enough time to talk about all of them today, but just a few that I'll highlight. We have a wonderful patient navigator program. Our patient liaison, Rosemary, is answering phones and emails and online messages every day, Monday through Friday, and she is able to help provide resources, financial resources, education, and other information. We also have, as you see on the screen, our virtual support groups. So we have 2 support groups. One is our Caregiver Connections, and the other is our Patient Perspectives. The Caregiver Connections meets on Tuesdays, the last Tuesday of the month, and our Patient Perspectives is on the last Wednesday of the month. And we also have many other different resources available. We have a patient podcast. We have a peer mentoring program with Immerman Angels. We have our KCA Facebook group. We participate with Smart Patients. We just have so many different ways for patients and caregivers and their loved ones to connect. And on the last slide here, we are proud to present, this is brand new. This is something we launched a few months ago, but we have special patient and caregiver care packs, as you'll see on the slide before. So these are special for patients and caregivers. If you scan the QR code or we'll provide these a link to the resources later, you can request one for yourself or for a loved one, and their specialty items specific for kidney cancer patients and their caregivers. Again, thank you so much to ABTA for allowing us to join today. And on this last slide here, you will see all of our social handles. Our website is kidneycancer.org. We're on Facebook, YouTube, LinkedIn, Twitter, all of the Instagram, all of the major social media sites. And please find us, and we're just happy to be here today. I'll turn it back to you, Ambreen.
Thank you so much, Amy. As a reminder, resources from the Kidney Cancer Association as well as the ABTA will be included in our resource handout that will be emailed post-webinar. And now, without further ado, I would like to introduce our fantastic panel of experts, each representing the different members of the care team that help support and manage kidney cancer brain metastases. Dr. Elshad Hasanov is a physician scientist and assistant professor of medical oncology at The Ohio State University Comprehensive Cancer Center. His clinical research and interests span various approaches focusing on understanding the biology of kidney cancer, including the unique clinical and biological aspects of renal cell carcinoma brain metastases, and developing better treatments for patients. Dr. Joseph Bovi is a radiation oncologist at ThedaCare. He takes a patient-centered approach to cancer care, placing emphasis on empathy and effective communication. Dr. Bovi's areas of interest encompass central nervous system tumors involving the brain and spine. He has specialized expertise and training in the precise delivery of high dose radiation to address these specific types of tumors. Dr. Toni Cao is a graduate of Northwestern University's Neurology Residency Program, where she developed an interest in primary tumors as well as the neurologic complications of cancer. She completed her clinical Neuro-oncology fellowship at Stanford University. She has a broad interest in treating metastatic disease to the brain and spinal cord. Her current research interests include novel metabolic neuroimaging techniques for both metastatic and primary brain tumor patients. And last but not least, we have Dr. Chetan Bettegowda, who offers comprehensive treatments for adult patients with benign and malignant brain tumors. He performs both open surgery and stereotactic radiosurgery for patients with metastatic tumors to the brain, and also provides stereotactic radiosurgery for other neurological disorders, including spinal tumors, trigeminal neuralgia, and skull-based tumors. Thank you all so much for joining us. I will now turn it over to Dr. Cao to get us started with an overview of kidney cancer brain metastases.
Perfect. Thanks so much for inviting me to speak at this webinar. I'll be giving a high-level overview of recognizing and caring for patients who have brain metastases from kidney cancer. Next slide. Perfect. And just kind of some introductory statistics. So overall, the lifetime risk of developing kidney cancer, or what we call RCC, is around 1.3 to 1.8% in North America and Europe. The incidence of developing brain metastases from kidney cancer estimated to be 10 to 13% over time. And the prevalence of developing brain mets at the time of diagnosis of RCC is less, around 1.5%. Out of all the subtypes of kidney cancer the most common one that goes to the brain is clear cell carcinoma, which with the incidence of about 8% of brain mets in those patients. We can go to next slide. And there are a couple of different factors that can increase the risk of developing brain mets from kidney cancer. These factors can be related to the tumor itself. So either having a clear cell histology or sarcomatoid differentiation, or having a really large tumor in the kidney that's greater than 10 centimeters. And then other factors are more related to the extent of cancer in the rest of the body. So if the cancer is a lot more advanced and has spread to other organs or involved other lymph nodes, such as in T2 to 4 disease or in nodal disease, then those patients would have a higher risk of developing brain mets as well. And in general, when someone develops brain mets from kidney cancer, oftentimes other organs are involved. So on the graph on the right-hand side, you can see other organs that are commonly involved when cancer has spread to the brain. So other organs would include lung, bone, liver, et cetera. And we can go to the next slide. So how do brain mets develop? Kind of a basic overview is that cancer cells break off from the primary tumor. They then kind of invade into the surrounding environment and then eventually enter into the blood circulation, travel through the circulation, and then end up exiting the blood vessels, and then can proliferate and end up colonizing and metastasizing to another organ. We can go to the next slide. And what are the different types of symptoms of brain mets? We can divide them into two big buckets. So one are focal symptoms. These arise because of a dysfunction of a specific part of the brain. And that can include things like weakness on one side of the body, numbness, tingling, seizures, etc. Then there are other symptoms that we call more generalized. And these are symptoms that occur because there's a lot of pressure buildup that develops because of the brain met. And these symptoms can be things like headaches, nausea, vomiting, or cognitive changes. And go to the next slide. So with regards to headaches, these occur in about half of patients who end up developing brain mets. Usually these headaches are pretty vague. They can be nonspecific, they can be dull, throbbing, they can be on one side of the head or on both sides of the head. They can be associated with a couple of things like nausea, vomiting. They can get worse with certain maneuvers like coughing, sneezing, or bearing down. And oftentimes headaches are associated with other types of neurologic symptoms. There is a classic quote unquote brain tumor headache, which is a headache that that is found in the morning or happens at nighttime and wakes people up. But that type of headache is actually pretty uncommon, even though we call it a classic one. And actually the more common type of headache that we see is kind of this non-specific vague headache in general. And in general, people who have multiple brain metastases, who have brain metastases that are growing really quickly or have infratentorial tumors, which are tumors that are kind of more in the bottom back part of the brain, those are the brain mets that typically cause more headaches. And go to the next slide. So how do we diagnose brain mets? We usually will take some sort of picture. So there are two types of pictures that we'll take. One is a basic scan called a CAT scan or CT scan. These will demonstrate pretty obvious masses, like you can see on the picture on the right-hand side, but they're not quite as detailed as MRI pictures. And brain mets from renal cell carcinoma in particular can be hemorrhagic. And I've kind of shown the hemorrhage part in there, which is the brighter hyperdensity kind of round circle there in the front. And that's because brain mets from RCC actually can be more vascular, as in there's more blood vessels that develop, and those blood vessels can burst and leak and then end up hemorrhaging. So that's kind of one clue that we'll see on a CAT scan that will make us think about a brain met from RCC specifically. Then we can go to the next slide. And then MRI is the other type of picture that we'll take. So this is our imaging modality of choice. And on MRI, brain mets are well-circumscribed masses that typically enhance with contrast. So on the left-hand picture, you can see that the well-circumscribed circle there, that looks a lot brighter on that side. And that's basically the contrast enhancing the tumor there. You can see there are two other pictures, and we look at different things based on the sequence of the MRI. So in the middle picture there, that picture is highlighting the swelling that occurs around the tumor. We also call swelling as edema in our medical lingo. And then on the right-hand picture, the black kind of dots there that I've pointed out with the arrow, that picture is actually looking at hemorrhage again, because these tumors can be hypervascular with a lot of blood vessels that might leak. So with these MRIs, we can see a lot more detail with regards to the brain mets and the surrounding area. And then go to the next slide. So how do we approach treating brain mets? So our toolbox, we think of 3 different treatment modalities. That includes surgery, radiation, and medical therapy. And surgery and radiation therapy, we refer to those things as local therapy because they're really acting on the brain itself. Medical therapy, which involves taking pills or IV medication, since it works throughout the body, we call that a systemic therapy. So these are kind of words that you might hear from your physicians, and this is kind of how we break down our different treatment modalities. And the next slide. So I'll talk about each treatment modality a little bit. So with surgery, there are a couple goals that we can think about. So one is local control, so removing as much of the tumor as we can. Because of that, we can also help with symptoms that come from the tumor or from the swelling around the tumor by rapidly decompressing that area. And then the other thing is by removing the tumor, we can send off that tumor tissue to the lab and run a lot of tests on it, look for different mutations and confirm a diagnosis that way. There are a lot of different factors that affect whether or not someone is a good candidate for surgery. So that can include things like patient preference, the tumor size, where the tumor is located, as well as kind of other things like the overall health of the patient and the status of the cancer elsewhere throughout the rest of the body. And if anyone does get surgery for brain mets, then we usually follow that with postoperative or post-surgical radiation therapy. That's to help prevent the cancer from coming back, which is what we call recurrence. You can go to the next slide. And so then with radiation therapy, the goal of radiation therapy is to cause DNA damage in the cancer cells that kills the cancer cells and then shrinks the tumors. There are a lot of different methods of radiation therapy that we'll get into a little bit at the tumor board after this. But so we can do radiation for the whole brain, which we call whole brain radiation therapy. We can narrow the beams a little bit more and focus in on the tumor itself. With 3D conformal radiotherapy, or we can even make it more precise and really just target the tumor while avoiding the rest of the healthy tissue with stereotactic radiosurgery. So you'll see a lot of different acronyms out there, but SRS is the acronym for stereotactic radiosurgery, and there are other kind of brand names of SRS like Gamma Knife or CyberKnife. But this is just kind of to show that there are a lot of different methods of delivering radiation therapy. And next slide. So kind of as we said before, post-operative or post-surgical radiation therapy with SRS, that very precise method of delivering radiation therapy, that is usually the standard of care. And this helps reduce the tumor from coming back and also helps reduce the risk of neurocognitive decline that can happen if we radiate the whole brain. There are other patients who can get SRS even if they don't get surgery. So if someone's not a surgical candidate, they could still get SRS for that brain met. Or if patients have multiple brain mets, even like up to 10 or so within a certain size limitation, they could also get SRS. And then whole brain radiation therapy, again, we historically used this more in the past, especially for patients who had multiple brain mets, but we use it less now because there's now evidence of neurotoxicity and cognitive decline that happens. And next slide. And then kind of briefly going over medical therapies, we kind of can divide this into two buckets. One is symptomatic management, really just treating the symptoms from the brain mets. The other is treating the tumor itself with different classes of medications. We'll get into that a little bit. So with symptom management, there are two kind of methods of doing this. So one is with steroids, which can help with swelling or edema from the brain met. The most common steroid we use is dexamethasone, but we try not to use this for too long because there can be side effects with long-term use of steroids. Anti-seizure medicines that you might hear about, the common ones we use are Keppra and Vimpat. And those are really to treat seizures after someone has had a first-time seizure to prevent the second, third, fourth seizure from happening. And then we can go to the next slide. And then as far as the tumor treating medicines that we typically use, and we'll get a little bit more into this at the tumor board, one class is called immune checkpoint inhibitors, which basically helps rev up the body's immune system to kill cancer cells. Immune checkpoint inhibitors can be a little challenging for the brain specifically because there is a more immunosuppressive microenvironment there with kind of decreased amount of certain immune cells and increased amount of other immunosuppressive immune cells. So it is kind of a challenge that we are working through, but there are a couple of ICIs or immune checkpoint inhibitors that have been studied. We'll go to the next slide. And so these are some of the names that you might see out there. So ipilimumab and nivolumab, this combination of immune checkpoint inhibitors was studied in a phase 2 trial with a response rate of 23%. There was another phase 2 trial that studied just nivolumab alone without the ipilimumab, again, with a different kind of response rate. But this is really just to highlight, the different names that you might see out there within the immune checkpoint inhibitor class of medications. Go to the next slide. And then the other class of medications is called anti-angiogenic therapies. We use a class of medicines called tyrosine kinase inhibitors, which block enzymes that are needed for cancer cell growth and division. There are many different types of enzymes that are blocked, and one of them can be the VEGF receptor. VEGF is an acronym for a long term, which is vascular endothelial growth factor, which basically helps promote the development of blood vessels and is highly expressed in kidney cancer. So there are a lot of different types of VEGF inhibitors and other kind of enzymes that are blocked with this TKI class of therapy. We'll go to the next slide. And some of these names that you might see out there, so sunitinib, cabozantinib, sorafenib, these are all different types of VEGF inhibitors and also inhibit other types of enzymes needed for cancer cell growth. And go to the next slide. And as you can see, we've talked a lot about different types of treatment. And there are also many different sequences of treatment that you can think about, different permutations of doing surgery first, then radiation, or maybe just doing radiation, then medical therapy, or even a combination of both, which has also been shown to have good impact on survival and overall brain control. We'll go to the next slide. And you can see this kind of highlighted in one of these algorithms here, where if we have a patient who has a single brain met, you can think about the size of the brain met, whether or not they're a surgical candidate, whether or not they're having symptoms, and decide, if that patient would benefit from surgery and then radiation, or maybe just doing radiation if it's a smaller brain met, et cetera. Then we'll go to the next slide. And then for patients who have multiple brain mets, if it's 10 or less brain mets, you can consider doing surgery if there's a dominant lesion, or just doing radiation therapy. If there are many brain mets over 10, then you could think about actually doing whole brain radiation to address all of those brain mets as well. And I'll go to the last slide here. So I know we kind of talked a lot in the past 10 minutes or so, but just kind of key takeaways to know. Risk factors for developing brain mets from RCC include specific characteristics about the tumor itself, as well as the overall systemic disease burden. Symptoms can include headaches, as well as focal or generalized neurologic symptoms. Treatment options that we think about are surgery, radiation, and or medical therapy. And medical therapy options, we have a lot of different classes of medications, but these can include immune checkpoint inhibitors and or tyrosine kinase inhibitors. And so then now that we have a better understanding of kidney cancer and brain mets, we'll start to explore how each member of your multidisciplinary care team can work together to determine the best course of action for our patients. And so I'll invite each of our panelists to come back on camera and take part in the simulation of a brain tumor board. I'll turn over to Dr. Bovi to moderate and present our first case.
That was just great. Dr. Cao, thank you so much for that excellent overview of brain metastases, and especially those specifically related to renal cell carcinoma. Before we had joined the full group here, we were having discussions of, at least back in my training, the rarity of brain metastases from kidney cancer. I'd related that back in the early 2000s, looking back at my resident logs for cases that I'd seen, I think I'd seen 5 cases of renal cell carcinoma that had spread to the brain. And now I'm seeing probably 1 every week or every 2 weeks. And I think a lot of that has boiled down to the successes that you've already pointed out so eloquently with regard to the advancements in systemic therapies, largely, targeted at immunotherapies for treatment of this disease process, and recognizing that metastatic disease to the brain is clearly part of the natural history of this disease. So thank you so much for that excellent overview. I think that sets the stage nicely for our discussion of these upcoming cases. So my name is Joe Bovi. I'm a professor of radiation oncology up in Appleton, Wisconsin. I work at ThedaCare's Regional Cancer Center here, and welcome to those that are on the call from my own institution. I see a couple familiar names here, so thanks so much for joining. But we're going to have a multidisciplinary discussion today about the management of brain metastases, specifically those related to renal cell carcinoma. And as Dr. Cao has already pointed out, treatment of brain metastases is clearly a multidisciplinary endeavor. We need specialists from neurosurgery, from radiation oncology, from neuro-oncology, and medical oncology. One of the things that we've clearly recognized, and Dr. Cao has already pointed out, is the benefits of systemic therapies in controlling intracranial disease. So welcome to my additional tumor board members, Dr. Hasanov, Dr. Cao, and Dr. Bettegowda. Thank you so much for agreeing to participate, and we're going to challenge your knowledge with a couple of these difficult cases today. So we can go to the next slide, Anne-Marie. So the first case that we'll present is a patient of mine who had a known history of brain metastases and had actually undergone stereotactic radiosurgery almost a year ago in January of 2024. The patient had 2 lesions, both of which were in somewhat close proximity to one another in the right parietal lobe. This patient was treated with fractionated stereotactic radiosurgery. Common dosing for the size and location of those lesions was 9 Gray times 3 fractions for a total dose of 27 Gray. We can go to the next slide, Anne-Marie, to look at least a representative example of the CyberKnife stereotactic radiosurgical plan that was used to treat that patient. There were 2 lesions, as mentioned, and both of which were in close proximity. We can see on the sagittal image in the lower right-hand corner, kind of the extent of the prescribed radiation treatment field, and where those 2 lesions were located in this patient's brain. As Dr. Cao had pointed out earlier in the presentation, stereotactic radiosurgery can be delivered with a number of different devices. CyberKnife is just one of them. This is a representation of a CyberKnife treatment plan, but there's also Gamma Knife and linear accelerator-based stereotactic radiosurgery that could also be used. We can go to the next slide. So initially, these lesions had responded well, but unfortunately, a couple of months ago, the patient had started to have complaints of left arm weakness and headaches. And an updated MRI scan was obtained, which revealed the following. We can go to the next slide. So here we see an example of the patient's MRI of the brain, and was wondering, Dr. Bettegowda, if you wouldn't mind just running through what you feel you see on this representative example, especially now that you have the background knowledge of where that patient's stereotactic radiosurgery treatment was at, and give an opinion on what your thoughts are on a differential diagnosis.
Thank you, Dr. Bovi. A very interesting case. This, unfortunately, is something we do see clinically on a fairly regular basis. For those who may not be used to looking at these images, I'll just take a moment to describe it. The right side of the brain is demonstrating edema or swelling or inflammation, which is the first panel. And the middle and right panels demonstrates enhancement or uptake of the gadolinium that's often given with these MRI scans. This mass appears to be slightly beneath the surface of the brain, but anatomically is near the motor strip and the motor fibers. So certainly in a delicate part of the brain. Given the history of prior radiation, one of the concerns that we would want to do is address would be to differentiate whether this is tumor cells coming back or radiation necrosis, as the slide suggests. And certainly the risk for necrosis would be high given the prior treatment.
That's perfect. Thank you so much. That was actually on our differential as well. One of the imaging sequences that I did not point out that the patient had also had was a regional cerebral blood volume study. And I'm wondering if either Dr. Hasanov or Dr. Cao would like to just interject on the benefits of advanced imaging that's available at some institutions in order to better differentiate the differential that Dr. Bettegowda had pointed out of necrosis versus, which is radiation injury to normal brain, versus recurrence of this cancer.
Yeah, I'm happy to speak on that a little bit more. This is, again, yeah, something that we unfortunately see not uncommonly in clinic and at our tumor boards as well. But yeah, just to kind of highlight the reason why we care so much about differentiating between recurrence versus necrosis is that recurrence, would mean that we would want to be treating the cancer since it has come back, versus necrosis or radiation injury. We don't want to give more tumor treatment because that might actually injure the area more, but we want to address the injury or the inflammation that happens from radiation. So oftentimes we'll say in clinic that it's kind of like having a really bad sunburn in that area because there's just injury to that area. And so that's why we care so much about differentiating between these two entities. But as you said, Dr. Bovi, one of the other types of pictures that we can use on MRI to distinguish between these two entities is looking at a cerebral blood flow map. And the idea is that tumors basically need a lot of blood flow for the cancer cells to survive and replicate and multiply. And so they will typically take up a lot more blood flow. And you'll see that on the map as like more red color versus necrosis or tissue injury, because it's not actually cancer cells dividing, it's actually injury. That area tends to be colder, so it'll actually look bluer on a map. So it's almost like a heat map that you can use. And so that is something that we actually use pretty frequently in our clinics to differentiate between recurrence versus necrosis. There are other kind of sequences that you might hear about, like ASL, which also is a kind of a surrogate of looking at blood flow in a different manner. And there are other types of metabolic imaging, actually, which aren't really used clinically, but more in the research setting, but actually like PET imaging, like amino acid PET. You can look at, different amino acids that are lining up more, that might suggest more tumor recurrence versus necrosis. But these, just the overall picture that we try to use as much information that we can get from MRIs to really differentiate between these two entities.
Excellent. That's great. Thank you so much. And this patient did end up having a regional cerebral blood volume study. And to your point, the heat map, so to speak, had indicated that this lesion was cold. There wasn't evidence of this area producing new blood vessels suggestive of recurrence of disease. I think one of the limitations of MRI scans that I always comment to my patients, MRI scan does a great job, I think, in terms of helping guide clinical decisions, but nothing beats true pathology or actually biopsy in order to figure out exactly what's going on. So why don't we go to the next slide and we can see where we moved on to next. So this patient did actually undergo a staged procedure on the same day where needle biopsy was done through multiple areas of that abnormality. In addition to then what's called laser interstitial thermal therapy, or what we have come to refer to as LIT. The biopsy, fortunately for her, turned out to be necrosis, which is actually favorable for her. But I was wondering, Dr. Bettegowda, if you could elaborate for us on what's somewhat of a new treatment entity over the last few years that has come to multiple institutions of utilizing this minimally invasive surgical procedure called LIT, and how that benefits patients, especially with those lesions in eloquent regions of brain or those in high functioning regions of brain.
Thank you for that question, Dr. Bovi. Indeed, as surgeons, one of the challenges we face is to do a surgery in a way that does not introduce a new neurological deficit or new neurological dysfunction. And as was mentioned earlier, this abnormality, this tumor, this mass sits in the region of the motor fibers and the sensory fibers, so certainly highly sensitive tissue. So the least intrusive we can be to understand what this is, obtain a diagnosis, and ideally treat it, the better. And so, as you mentioned, one of the burgeoning technologies that allows us to do this, particularly in the setting of a tumor or a metastasis that's been previously radiated, is a technology called laser interstitial thermal therapy. And to describe it briefly, individuals are placed under anesthesia. A very small opening is made in the scalp, and a small hole is made in the skull. And most frequently, under computer-guided navigation, we're able to place a small catheter into the enhancing area, into sort of the core of that mass, and sample it for pathology. And in some cases, we're able to sample multiple areas, as was done here, in order to ensure that we have a good understanding of what that mass represents. And if the results of the pathology suggest that this is something that would benefit from ablation, like radiation necrosis, through that same port, through that same cannula or catheter that we've placed inside the mass, we can introduce a catheter that has a laser tip on the end of it. And that laser allows us to heat up the area. So what happens is then that patient is placed inside an MRI scanner, and in real time, we're able to do thermography or measure the temperature as that laser is activated. And as that laser introduces higher and higher levels of heat, it allows the surrounding tissue to be destroyed. And this is very effective for treating things like radiation necrosis from radiation therapy without the need for going in there and doing a bigger surgery, requiring a bigger corridor and more in sort of disruption of brain tissue. This procedure can be done fairly quickly. At the completion of the ablation, that little catheter is removed, that small incision is closed, And the length of stay and recovery for the vast majority of patients tends to be an easier one than a traditional craniotomy, where we have to make a bigger incision, a bigger opening in the skull.
That's perfect. Thank you so much for that eloquent explanation. As we can see here, this patient had a very nice procedural outcome with significant reduction in mass effect caused by that previous necrotic tissue being thermally removed. And we can easily see as well that the patient's cloud of edema on the panel to the far left is significantly less. She had a dramatic reduction in her symptom profile, and left arm weakness resolved completely. As with many things in medicine, there are multiple opportunities for multiple different treatment regimens. And unfortunately, some patients are not considered appropriate surgical candidates, even for a minimally invasive technique like LIT. And was wondering if either Dr. Cao or Dr. Hasanov could talk about non-surgical interventions for changes of necrosis that we see in patients who've undergone stereotactic radiosurgery for brain metastases in the setting of VEGF inhibitors.
So the common first-line treatment we use in this setting is steroids, which is not very much liked by the physicians, especially in the setting of the immune checkpoint inhibitor. And the second alternative is bevacizumab, that is basically targeting the VEGF for the vascularization of the tumor. And the third line, actually, as of now, is LIT, which I would say that in this case, it would be more valid given due to the size of the lesion, location of the lesion, that you wouldn't like the chance of the failure and also high symptoms. So that's other systemic therapy options for the management of the radiation necrosis.
Perfect. Dr. Hasanov, thank you so much. I appreciate you. So this patient's done well. Obviously, with necrosis, there's no further need for treatment. Alternatively, though, sometimes when we would do a biopsy prior to LIT, there would be evidence of recurrence of disease. And the unfortunate thing with regard to recurrence versus necrosis is that both can look very similar to one another on standard MRI scans. If there was presence of recurrence of disease within this cavity, we would give consideration to further focused fractionated radiation to the cavity that was created by LIT in order to offer a more durable outcome for control of that patient's disease process. So lots and lots of options in different pathways. There's actually an open clinical trial sponsored by the manufacturer of at least the NeuroBlate device, Monteris, looking at this exact pathway of biopsy and LIT followed by stereotactic radiation for patients with recurrent metastases. And we'll get more information from that study based upon what the optimal pathway is and optimal flow of patients' treatment who present with this common complication from stereotactic radiosurgery. So that was an excellent first case. Thank you. Why don't we move on to the next? So this next patient of mine is a 65-year-old with a history of clear cell renal carcinoma. And as Dr. Cao had pointed out during her presentation, this is a pathology that commonly spreads to the brain. This patient was initially, their systemic disease was actually treated with nephrectomy alone. Staging study at that time was negative for any distant spread, and including a baseline MRI of the brain. In June of 2024, just a few months ago, the patient was on vacation and again had complaints of left arm weakness and headaches. The medical oncologist had ordered an MRI of the brain, and we can take a look at that imaging. And Dr. Bettegowda, I'm going to tap your expertise one more time, if that's okay. You did such a nice job on that prior MRI description. I'd like you to take a peek at this. And then following that, offer your opinion on what your considerations would be if this was a solitary lesion, meaning the only lesion we saw in the brain with these clinical findings.
Thank you, Dr. Bovi. Indeed, again, we see on the left side of the screen, which represents the right side of the brain, a contrast enhancing mass, this white sort of very circular lesion on the right panel. On the left panel, we can see this extensive area of white, which is again edema, inflammation, that's actually pushing portions of the brain to the opposite side and displacing it. So what we call mass effect and shift. And so a solitary brain metastasis causing symptoms with associated mass effect, really the treatment of choice, especially an individual like this who's otherwise well from a cancer and overall perspective, would favor surgery to remove the tumor, to reestablish a diagnosis, as well as to alleviate the pressure on the brain. I think there can certainly be adjuncts that can be used after surgery, but I think the first step would be surgical resection in this case.
Perfect. I agree with you. You'd be a great NFL commentator, because that's exactly what I would have recommended as well. And that's actually what happened for this patient. We can go to the next slide. So just to clarify again, some additional clinical information, the systemic staging was negative for additional Mets. Dr. Bettegowda has also given an excellent surgical opinion in recommending craniotomy. A 24-hour post-MRI, 24-hour post-surgery MRI scan revealed the following slide. And Dr. Bettegowda, if you want to comment again on what we see here in comparison to what we saw on the prior slide.
Absolutely. You know, it's been a very successful surgery here. That enhancing mass in the right frontal lobe has been completely removed. We do see residual edema in the left panel, that sort of white signal in the brain. We know that's very normal. That subsides sequentially over time once the mass and sort of post-operative changes quiet down in the coming days to weeks, but appears to be a very beautiful surgical procedure.
Wonderful. Yep, we agree with the same. Patient still did have a fairly significant cloud of peritumoral edema, as we can see on the panel on the left-hand side there, but otherwise a very successful resection of tumor. We can go to the next slide. So following this surgical procedure, there's lots of options for treatment. One that was previously considered in the past was observation, but I think for at least the panelists that we have on this particular call, that would not be the recommendation for following this patient's surgery by just observing it. We certainly know, and while we wish that neurosurgeons could operate with microscopes on their eyes where they were plucking individual cancer cells out of a cavity, we certainly know that that cavity would still be contaminated with residual microscopic disease, with over an 80 to 90% risk of recurrence at a short interval of 3 to 6 months. Another option for treatment that was considered in years past was surgical resection followed by whole brain radiation therapy. I think, just to speak for my own field, our pendulum has strongly swung away from whole brain radiation, especially considering the known deleterious cognitive effects that can happen in patients that would receive whole brain radiation. The treatment choice that I would recommend for this patient would be consideration for stereotactic radiosurgery. There are some pundits that favor single fraction over multifraction. For cavity treatment, I've tended to favor fractionated stereotactic radiosurgery for these patients, especially for the volume that we currently saw that would need to be treated on the prior slide. Comments with regard to those treatment recommendations from the other panelists?
Yes, I mean, like, given that the potential of the residual disease over there, stereotactic radiation would be ideal. In fact, as we speak, there was a paper just published in Nature Communications from Emory Group describing some immunological concepts about this pre-post-operative radiation, and there are many other in the series as well, to consolidate the role of the pre or post-radiation to the surgical cavity. From the systemic therapy perspective, I want to highlight, if this patient does not have any other site of the disease, I would advocate for the adjuvant pembrolizumab treatment as of now. Even though we don't have a data, what will be the recurrence rate if we use this in the adjuvant setting, at least we know that from the adjuvant pembrolizumab study, that patients who has M1 NED disease that had the highest benefit from the adjuvant treatment, and I think that would be important to integrate from now on to our practice. Moreover, the challenge is, as of now, the concept of brain metastasis with renal cell carcinoma rarity may make people to think away from the necessity of the surveillance. and which would end up having larger tumors developed in brain versus a smaller tumor that we can address easily with stereotactic radiation or even maybe systemic therapy soon. So either physicians or the patients, I think, should be encouraged and willing to have the regular brain MRIs, I would say at least every 3 months, to diagnose early in asymptomatic phase, which many other studies from melanoma, lung, breast has shown that symptomatic versus asymptomatic disease, the outcomes are very different.
Yeah, I agree with you 100%, Dr. Hasanov. And, I feel lucky, and I'm sure the three of my other co-panelists would agree with the same, that, I feel lucky that I work with a group of medical oncologists that are very forward thinking in this regard as well, and do get regular standard brain MRI surveillance in asymptomatic patients with renal cell carcinoma in order to pick up early recurrences or metastatic lesions that can be managed successfully, as opposed to what we'd see potentially in the next case. But this patient did move on to receive stereotactic radiosurgery. We can go to the next slide. This is a representative example of the patient's CyberKnife stereotactic radiosurgical treatment plan. That lesion did come out and contact the outer rim of the brain, what we call the dura, or the lining of the brain. And for that reason, we extend those radiation treatment fields out along the dura in order to pick up any potential risk of microscopic disease that may have seeded that open dura at the time of surgical resection. This patient had received fractionated radiation therapy, 30 gray and 5 fractions of 6 gray, and is doing just great with no concern for recurrence of disease, and has moved on to systemic treatments in line with what Dr. Hasanov had pointed out, with immunotherapies on the backside of this treatment. Any questions or comments from the panelists with regard to this case? And Ambreen, if you could give me a time check just on our ability to move on to case number 3.
Yeah, we have time for the third case. Thank you.
Okay, that's fantastic. And so let's move on to this patient. Unfortunately, another that I'd seen recently, a 67-year-old woman with a known history of metastatic renal cell carcinoma. So she was already on immunotherapy. She'd already had prior radiation. She'd had focused, what we call stereotactic body radiation, to a lung lesion a few months back. I had treated her metastatic lesion successfully also with stereotactic radiation to the 10th thoracic vertebral body. Unfortunately, she had presented with complaints of headache and nausea, and we had ordered an MRI of the brain, which revealed the following. And Dr. Bettegowda, I'm going to tap your expertise one more time as our stand-in neuroradiologist today, and offer an explanation of what we're seeing on this terrible scan.
Thank you, Dr. Bovi. Yes, unfortunately, it is something that we do see occasionally. Thankfully, not as commonly as perhaps we once did, but we can see on both of these images that are slices through different parts of the brain, multiple enhancing to the white areas, tumors in both sides of the brain, in multiple different lobes, superficial and deep. Certainly a scenario where surgical intervention would not be able to change the natural history, and would look towards other alternatives for definitive treatment here.
Thank you. We can go to the next slide, Ambreen. So this patient was started on steroids. Unfortunately, her symptoms did improve. I'm going to open it up to the group on how this patient's case would be managed at your own institution, and what considerations for treatment would be made at your Stanford or Ohio State.
So in terms of the volume of the disease, Ohio State University has actually, I would say, reputation even in this kind of challenging cases to tackle with stereotactic radiation in multi-volume, metastatic disease. Like the standard is 10, but I have seen cases that they have tackled like 15, 20. Very proud of the team for that efforts. However, the number is not the problem. I would say the volume is another challenge in this case with 2 large volume metastases that might be highly toxic for the patient to tolerate stereotactic to those areas. I would say the standard approach will be the whole brain radiation treatment with hippocampal avoidance and followed by systemic therapy. But I think the space is open to integrate if the patient doesn't want to do the whole brain radiation treatment, what other surgery plus stereotactic strategies that can be taken, large volume disease surgery followed by small volume disease, stereotactic radiation. And in terms of systemic therapy, I want to quote some numbers from our and others studies. So avelumab plus axitinib in the Javelin study that we performed the post-hoc analysis, post-radiation, the median progression-free survival with patients with brain metastases was 4.7 months. And the French study with nivolumab single agent was also 4.8 months as a median progression-free survival. One of these is intracranial and other one is the overall progression-free survival. And more recent data with pembrolizumab plus lenvatinib that showed that it is 8.7 months progression-free survival. The cohort is small and however, it is intriguing to see that the number is doubled. And in fact, I want to give a shout out for KCA. They funded our first young investigator grant a while back, which led to this study now that we will be opening the pembrolizumab plus lenvatinib study. It will be a multi-center study testing this regimen in patients with renal cell carcinoma brain metastases. But since it's already available as a standard of care, I think we have seen great results, disease control, that it can be considered. Same for, I would say, cabozantinib. There's already published good data about the retrospective value as a single agent that I think these are great options. So in a nutshell, systemic therapy, I would favor either cabozantinib or lenvatinib-based multi-TKI in combination with immunotherapy to improve the maximum capacity of the disease control.
Dr. Cao, anything to add to that?
I completely agree with what everyone has said. From the neuro-onc standpoint, we always try to see if we can really spare the brain from really toxic treatments. And so we try to see if we can avoid whole brain radiation if we can. But based on this patient's scan, there is a threshold of if there is enough brain metastases that are large enough that just can't be taken out surgically, and can't be safely all irradiated by SRS, then we kind of are left with going with whole brain radiation with hippocampal avoidance, which hippocampal avoidance helps with the neurocognitive impacts of whole brain radiation. So that's kind of the method of doing whole brain now these days, in addition to adding memantine, which has also been studied to help with cognition as well. But yeah, I would agree that at Stanford, if this case was presented at our tumor board, we would most also likely be going with whole brain radiation followed by systemic therapy as noted by our medical oncology team.
Yeah, perfect. That's great. As mentioned previously, even within my own field, we try to do stereotactic radiation as much as we possibly can. There is actually an open clinical trial that's accruing right now from the Canadian Cancer Care Group that is actually looking at this very question in patients with multiple metastases, whether stereotactic radiosurgery versus hippocampal avoidant whole brain is superior. And we'll certainly be all awaiting the results of that trial in order to help guide some of these clinical decisions. I think the outcomes of that trial, though, will be clouded a little bit, as Dr. Hasanov and you, Dr. Cao, have already pointed out, with the effectiveness of systemic therapies, that we never had the benefits before of seeing additional intracranial response almost in an unprecedented way with some of the targeted drugs that you guys are able to prescribe now specific to renal cell carcinoma. You'd mentioned cabazapinib, Dr. Hasanov. That's been a brilliant drug that I've come to love as a radiation oncologist, knowing that I'm going to get some additional bang for my buck with the radiation treatment that I would prescribe to continue to see intracranial control with the administration of that drug after my treatments are done. So this patient actually did go on to receive hippocampal avoidant whole brain radiation, and we can go to the next slide. And here we see a representative example of her treatment plan. The hippocampi, as Dr. Cao had pointed out previously, are two C-shaped, centrally located structures in the medial temporal lobes. And with advanced radiation treatment planning and delivery, we can conformally avoid giving a dose of radiation to that structure, which could lend itself to cognitive decline if that was treated with a homogeneous dose of radiation. Along with the whole brain radiation, though, are there additional drug therapies that would be recommended for this patient in order to further enhance the cognitive outcomes that we could hope to achieve with just hippocampal avoidant whole brain alone?
Yeah, I think memantine is the drug that has been studied in kind of the larger rad-onc literature that's been shown to help improve neurocognitive outcomes when given with hippocampal avoidance whole brain. It basically acts as a NMDA antagonist, and it's an oral pill that people will take both before, during, and usually after radiation therapy to help with their memory and cognition later on.
Perfect. That's exactly what I had in mind as well. And this patient will be on memantine for the next 6 months following her her whole brain radiation therapy. For lesions that are larger that we had seen on this patient's initial MRI scan, I would also give some consideration to a stereotactic radiosurgical boost to those lesions that were greater than 2 centimeters in size. Renal cell carcinomas across their different variants have shown sometimes resistance to modest fractionation and dosing that we would use with whole brain radiation. And so, even though Dr. Hasanov is going to follow up those treatments with additional systemic therapies that may continue to provide control for disease in this patient's brain, we would give consideration to additional focused fractionated radiation to those lesions that were larger in order to provide for longer, more durable control of those spots. So comments on that treatment recommendation, that's something that we would commonly employ at our own institution. Dr. Bettegowda, what do you guys do at your institution for similar situations?
That's certainly something that we counsel patients about, Dr. Bovi, that the larger, more bulky tumors may be less responsive. In general, I think we favor a short interval scan and then, if need be, supplement pretty quickly if there's signs of continued growth of the larger, bulkier disease. But I think the approach you recommend makes a lot of sense and is very, very reasonable to consider.
Sounds good. Any other thoughts on this more challenging case?
I would also advocate for that, especially for the large volume disease. But for the smaller sites, I think we should give a little bit time and opportunity for the systemic therapy to show efficacy or failure. Because from the biological perspective, when we use the high-dose stereotactic radiation, we kill basically all the engagement of the T cells and the immune microenvironment there. If we can, I think that would be the ideal strategy. In fact, the trial that is coming up, we decided to add out of standard of care another short interval, like 4 weeks MRI, to make sure that when you're opting not to do the stereotactic radiation, you would be able to monitor the disease stability in 1 month so that everyone sleeps safely and with no anxiety.
Sleeping with no anxiety would be a good thing. I agree with you 100%. And Breen, could we go to the next slide? That may be it.
Yes, thank you all so much for that fantastic discussion and being able to see what it looks like when you are working together to make important decisions regarding the care and management of kidney cancer brain metastases. Now that we have explored some of these different treatments and how your care team works together to manage brain metastases, let's transition to getting a better understanding of what this all means for patients and caregivers. We are so honored to have two incredible panelists joining us today for this portion of the talk. Joe Horn has been involved in the cancer research community for over 15 years as president and CEO of the Hope Foundation for Cancer Research. Her involvement, however, took a far more intimate and powerful turn when her husband, Aaron, was diagnosed with stage 4 renal cell carcinoma in December of 2022. He's treated at the University of Michigan, where he was initially treated with immunotherapy and underwent radiation and a craniotomy for his brain mets, which is now stable. Also joining us is Mike Turley. He is an accountant for the state of West Virginia, and at the time of his diagnosis, he lived a very active lifestyle, an avid golfer, hiker, jogger. He was diagnosed with stage 4 renal cell carcinoma that metastasized to the brain in March of 2021 after experiencing a seizure. He has undergone 2 craniotomies, immunotherapy, as well as a nephrectomy. Joe and Mike, we are so honored to have you. Thank you so much for joining us. I'm going to stop share here so that we can see you and have a little bit of a discussion about what this has been like for you. To get us started, I'd like to hear a little bit more about what it was like when you first learned about this diagnosis. And Mike, I'd like to start with you. If you can tell me a little bit more about how you found out about your diagnosis and what that was like for you.
Sure, Ambreen. As you had mentioned, I was very active, golfed, jogged, hiked a lot, did a lot of traveling. I actually was working at home during the pandemic. And at lunchtime, I went to my exercise room to do a quick jog at lunch. And I had a seizure. I'd never had a seizure before in my life. Had not really had any headaches or the nausea or any of the classic signs of this disease. Basically was taken to the emergency room. My wife, she took me to the emergency room, and while I was there in the emergency room, I had a second seizure. That led the doctors to say, okay, we need to get him in and have a scan. They did a CT scan, found a tumor, and basically traced that tumor backwards to a very large mass on my left kidney. So this was all just, it was very surreal because I had never been on any kind of medicine. I'd never really been sick. Never really had any of the classic symptoms. And it just completely came from left field. So it just really took us aback. And it started me down this whole journey. And you know, I'm learning new things each day with this. So it for me, it was something that just was a shock, was a surprise, but I'm very grateful that it didn't happen when I was driving or doing something that could have injured myself or someone else. It's very interesting. The seizure that I had while I was on the treadmill, I was still able to control my motor skills enough to come off from the treadmill and make my way to the foyer and sit on a bench until it passed. Once it passed, I was able to get my wife to come home. She was working in town. She came home, and like I said, we went to the emergency room. But you know, this is just a disease that, for some of us, just comes out of nowhere. You know, there are the telltale signs may not necessarily be there.
Thank you so much for sharing that. just like you said, it can sometimes come out of nowhere. And Joe, I know for you and Aaron, the experience was a little bit different, where Mike, you kind of found out about this after having that seizure, after having a symptom from that brain mets. But Joe, your experience with Aaron was a little bit different. Can you walk us through what it was like when Aaron found out about his diagnosis?
Yeah, absolutely. And let me also say thank you to all of the patients and families who are logging on. I know that it can be a hard space to navigate when you're just trying to suck in all the resources, and to the docs who took care of the tumor board. It was really fascinating. Yeah, I hate to just concur with what Mike was saying in terms of coming out of nowhere, but we were also in COVID. We have 2 young kids, and everybody got COVID because that's what started to happen. And Aaron was just not getting better. So finally, after the rest of us were fine, he went to the doctor to see what was happening, and he presented with a hemoglobin. He was asymptomatic besides just kind of feeling trashy post-COVID. A hemoglobin of just above 4. And that was obviously a trigger. So the blood work was really what pointed it. Otherwise, asymptomatic, and he went straight to the ER. And after a couple of days of chasing imaging, he had presented. He was 47. He presented with a 12-centimeter tumor on his kidney. He had an 11-centimeter tumor on his liver. He had 3 6-centimeter tumors in his lungs, some tumors in his ribs. But otherwise, he would have, he was at REI Christmas shopping when the doctor's office called. So, thankfully, there wasn't seizures or danger. But yeah, it can kind of get you out of the blue, and then everything turns upside down.
And can you tell us a little bit about when he found out about his brain metastases and it progressed in that way?
Sure. So that was he started treatment. He did systemic therapy. He was on a combination therapy of ipilimumab and nivolumab starting in January 2022. He was not able to tolerate ipilimumab. It's a hard drug for anyone that's on it. It is a really hard drug. It gave him an immune-related colitis. So he went to nivolumab monotherapy. And 3 months later, they discovered metastases in his brain for the first time. And that was after, just 3 months between MRI. So it was quick. They found 7 lesions at that point. And, for those of you who are caregivers, I always say that the relationship comes first. So he's still my husband. And, when you say, like, why are you walking like that? Because the first thing I noticed was his gait, right? He was walking all of a sudden like he was 9 months pregnant. And he was super defensive. What are you talking about? Leave me alone. And, finally, we just decided to go to the ER because he started to lose his balance. So it's, and yeah, so that was shocking. There was it felt different, honestly. I've been in cancer research for a long time. It feels different when it goes to the brain. I think it feels a lot scarier. I think that socially and psychologically, the brain is really important organ. Not that the others aren't, but it's sort of like, what is our life, right? And I think that there's also, from a research perspective, it can be a little bit of the unknown. And we certainly have seen that from the clinicians, who are incredible, super grateful. But there's just feels like there's a lot of just throwing a dart and seeing what happens. So he did RS at that point, and it held steady. I'm sorry to report that he did have progression last week. So he had been stable for a while, but we're sort of back in the gamut again.
I'm sorry to hear that. And thank you for sharing that with us.
Oh, absolutely. It's the reality that we all deal with.
So, you talked about kind of shooting a dart in the dark, right? And a lot of this is the unknown. And part of that is making those important decisions regarding your treatment and your care, and trying to figure that out while you're getting all this information unloaded onto you from your healthcare team. I'd like to hear a little bit about, what options were presented to you and how you navigated that. If you had to advocate for yourself at all. And Mike, maybe we could start with you on that.
Sure. You're exactly right. You're healthy 1 minute, and then the next moment your whole life has changed. and you're having all of these, for me, I'm an accountant, so I'm not as versed in medical terminology. So I'm having all these different medical terminology thrown at me. And, at some point I just had to say, I need a break. I need to process this. And fortunately for me, I had my wife with me in the ER, and, I just sat in silence for a good deal. And then I started to think, the logic in me kicked in. And I will say that from the time I was diagnosed until my first craniotomy was about a week. And I stayed in the hospital the whole time. At that point, I really felt, and I even commented to my wife, I felt like my ability to make decisions for my own care had been taken away from me. And that was for me, it was very dehumanizing. It was disconcerting and very dehumanizing. But once I had the craniotomy, I was able to come home. And fortunately for me, when I came home, the craniotomy went very well. I kept my high functioning cognition. So I was able to do research, and my wife and I began to do research. One of the things that we did was the Kidney Cancer Association. We did webinars and things with them. And I kind of felt like as I progressed, I was very blessed in the fact that my local oncologist, who was not an RCC specialist, put me on the combination of pembrolizumab and lenvatinib. And that really started to work for me. But the more I went into it, the more I realized I needed to advocate for myself. So I would go out to the Kidney Cancer Association website and discuss with other patients, and my wife would discuss with other caregivers to get questions and ideas of, okay, well, what about this? Well, what about that? And I stayed with my local community hospital for about 2 years. And I was advocating for myself the whole time, asking about, okay, what about a nephrectomy? The medication seemed to have this under control. Everything seems to be controlled right now. What about a nephrectomy to remove this? And, I just met with resistance, and it was my choice that I wanted to have that done. So I advocated for a second opinion. But I wanted a second opinion, not just from any medical oncologist. I wanted one who specialized in the disease that I had. And that to me meant so much, because I was talking with someone who was not looking at all of the different cancers that were coming in. They specialized in what I had. And that advocacy on my part to do that made me feel like I was back in control of a small portion of what was going on in my life. It's a tough thing. Yeah, I struggle with it. I have good days, I have bad days, but having a comprehensive center that I can go to, that I know they have a tumor board, they have specialists, and we can consult and kind of formulate a cohesive plan with my involvement, it puts me at more of an ease. And that's what, I guess, if that's one thing that I would like to impress upon everyone is advocate for yourself. There's a lot of resources out there. Advocate for yourself, and don't just accept what one person tells you.
Thanks so much for sharing that, Mike. I think that's so important. That's such a important piece of advice that you shared, because I think especially for those patients like yourself who are coming into this without that medical background or knowledge, it can seem really intimidating to advocate for yourself, but you did it, and it really, that was important for you, for your quality of life, for you to feel more in control. And I do want any of our patients and families on today to remember that you do have a say in your care, and you can advocate and speak up for yourself as well. And Joe, I'd love to hear what your experience with Aaron was like on that, going through this as a couple, and especially you, given your background, having some of that medical knowledge and experience and insight in clinical trials and research. How did you balance that, listening to what his wishes and needs were, and making those important decisions together?
It's never easy, right? And I think it maybe doesn't look the same every single time. One of the things that I've come to learn, and I feel grateful. So, Aaron was first diagnosed with brain mets in 2022 in the spring, and then he had a craniotomy in spring of this year, so 2024. And now I guess we're looking at radiation next week. And as he's lost, at one point, he has reduced movement in his right side of his body. He's had a lot of language impairment. Most recently, he's having some cognitive issues. So as the symptoms present, they obviously have different priorities. Aaron's a musician, right? And he plays guitar. And so he's a professional musician. When he lost the ability to play guitar, that's really gutting. So working and just knowing him, what his use of his right side, which was a result of necrosis from a cerebellar lesion, was more important than perhaps the oncologist might think, because you think necrosis. And it was interesting, I heard in the tumor board that, there's not much you can do to treat necrosis, but we forget that there's like all of the OT and the PT and like the endless appointments. And so sort of understanding what's out there and knowing for him his priority. And I think that in general, clinicians do a wonderful job of understanding that every patient's priority is different. But I think when you have an advanced stage cancer, there's something about the time point of those priorities that always shift. Right now, it's just spending time with our kids. So his mobility is as long as he's got that mobility to be able to like walk on a soccer field is like a big deal. And so how can we make sure that he's got the physical therapy and whatever needs he has to make sure that that can happen is part of his treatment plan as well. So it's not necessarily like blast the cancer at this point, get the cancer out of there. Of course, that's there, but there's managing the side effects, which I think with brain metastases alone feels just sort of lawless, right? It feels like it could be anywhere, especially when we're looking at the ICIs or the immunotherapies.
Yeah, treating the disease is so important, but equally as important is, just like you said, what is your priority, your quality of life? What are the things that are important to you? And are you still going to be able to engage in those things the same way? Thank you so much for sharing some of that insight with that. And I know we can chat all day, but I do want to make sure that we save some time to take questions from our audience. So to wrap us up, I'd love to hear from each of you, what's one piece of advice, one piece of insight that you would really want our attendees to take away from maybe your own experience or what you've learned along the way. Mike, let's start with you, and then Joe, I'll have you chime in as well.
Sure. The one thing that I would recommend, and it's twofold. Don't take for granted the symptoms that you're having. Have them checked out and advocate for yourself. Make sure that you are comfortable with your treatment care team, and advocate until you are, because this is your life and you're important. So advocate and mention your symptoms. If you're having a symptom, absolutely go and have it checked out. It's better to have it found early than much, much too late.
Thank you. And Joe, is there a piece of advice that you'd like to share with our audience today?
I think that, Mike, that's really solid advice. Something that you wouldn't even consider a symptom, like walking strangely. it's always telling to me. The other thing, it's hard to say this kind of advice without sounding trite, but like, don't write the narrative, right? Sometimes we find ourselves, and Erin finds himself in a certain treatment predicament, and, you're like 6 months from now when, we hear this all the time with all the mindfulness things that people talk about, but just being where you are, talking with your care team and meeting the moment as it comes, because it always looks different, and it may be for the better, but it also may be for the worse. It is what it is, but it's usually not what you think it's going to be, right? It just is what it is.
Thank you both so much for taking this time to share your experience and that wonderful advice and insight for our audience here with us today as well. I do want to open it up now to questions from our audience. So just as a reminder, if you have questions that you want to ask, please type and submit it using the Q&A button on the screen. And at this time, I'll invite all of our panelists to please come back on camera, and we'll go through as many questions as we can. All right, let's see what we have here. So one of the first questions I see is asking about the different types of renal cell carcinoma. So we have translocation renal cell carcinoma, clear cell renal carcinoma. Can you talk about the frequency in brain mets? Is it different for different types of kidney cancer or renal cell carcinoma? Maybe Dr. Hasanov, maybe you could talk to that.
Yes, I can comment on that. So most of the data obviously is coming from the clear cell renal cell carcinoma, and I will report various findings from different studies at different stages of the disease. So patients who has nephrectomy in clear cell renal cell carcinoma, post-nephrectomy during the follow-up period, like from series of adjuvant studies that has been in the past, 3% of the patients eventually develop brain metastases as one of the first site of the disease. So that's something important to note, and I think that will also answer the question down in the line. If you're asymptomatic, would you do the brain metastasis? So I think that's the calculation for the 3% that can be considered. Now, in terms of the patient who has the metastatic disease diagnosis and whether the brain is site of the disease or not, as an additional site of the disease, let's say if you go to the clinic and you find to have a lung nodule, would you do the brain MRI and define that? I would say yes, and that is actually part of the NCCN guideline as part of early screening to define what is the pattern of the disease. And that has been reported 8 to 10%, I would say, the first time when you have a metastatic disease. So you have a synchronous other disease development. Now, in terms of metachronous, which is like first you have first site and then another site over the treatment, and that is really dependent on how much you have been having the kidney cancer over the course of the treatment. For example, one of the best first-line options, nivolumab plus ipilimumab, has been reported that post-nivo-ipi, 28% of the patients who has a progressive disease has a brain as a new site of the development. So that's driven by two factors. One is that the longer the patient is on the treatment, there is a more chance for the circulating cells to land in the brain. And the second factor is related to the immunotherapies, effectiveness, or challenge to be able to do a good surveillance in the brain microenvironment. So that is actually I would say, why Dr. Bovi, when he was resident, seeing 5 patients versus now seeing once a week is the delta and the change. That it's first good that we now have a better treatment, but it's bad that now there's more need than ever that we need to do a better job in the brain metastasis of the patients. Now, in terms of quoting the numbers for clear cell, non-clear cell, chromophobe papillary, from the same report from the IMDC, that where there's a multi-institutional contribution to retrospective data analysis, the data shows that in that same report from the same methodology of the I would say some level of subjective and objective values can be considered, since it's retrospective, not a prospective data collection. 8% of the clear cell has been reported brain metastasis on another, and 3% of papillary and 3% of chromophobe. Unfortunately, for translocation, we don't have exact number that I can quote, but I would say that it will be probably similar. But there is still some challenge, I would say, how well we treat the translocation renal cell carcinoma in the beginning, so that the patients live long enough that the time will be the essence to allow the disease to develop. So what I'm quoting is cumulative incidence. If you ask me, I think if this disease would be managed well from the extracranial side, that the patient live a longer time period, there is a higher cumulative incidence of the brain metastasis that will be observed. So that's why I would say it's a good idea to advocate, as Mike mentioned. I can't like state enough how it's valuable for me to have Mike's opinion in his care, because it makes it much more easier to say that which treatment is better for that choice. So same in your case, if you're saying that I want to get brain MRI because I'm worried, then the physician who is caring you would be more willing to have that challenge and fight with the insurance to make sure that it's going to be paid and it's going to be covered, versus, well, it's not important for me, then it would be hard to have that battle.
Thank you so much for sharing that insight. And Dr. Bovi, I know you shared a couple clinical trials, and we have a question here just asking if you can share any insight on navigating clinical trials. You know, how do you find the clinical trial that's appropriate for you? And Amy, I'd love if you could jump in on this as well, because I know Kidney Cancer Association is a great resource that can be helpful.
Yeah, I think it's a great question, especially for the patients that we have on this phone call. And I know I can speak for the rest of our tumor board panel as well. We all view clinical trials as an absolute necessity to further our field and fund of knowledge in these situations of metastatic disease to the brain. I can honestly say, in a 20-year career of treating brain and spine metastases, there's just been an absolute explosion of new data over the last 5 to 7 years with regard to how to best manage these patients. And we finally actually have clinical trials that have paved the way to what we just presented today in our tumor board, that has really defined the standard of care. But I think all of us that treat patients with brain metastases across multiple pathologies can share we have a long ways to go. And, there are, I always tell my patients that, when you're diagnosed with brain metastases, this becomes a very reactive thing. We see a new abnormality, we treat it. What I would love to see happen, and I think there are clinical trials coming down the pike to help with that, is that we can get a little bit more proactive with regard to how we manage this disease process. And many of those things we just heard about today with regard to targeted and systemic therapies that actually do penetrate the central nervous system, not just to treat disease there, but to Dr. Hasanov's points and Dr. Cao's points made previously, but perhaps even to prevent that disease process from getting up there to begin with, controlling that circulating volume of tumor cells so that we don't see disease spread to the brain. We can't do what we do. We can't offer the recommendations that we offer in the absence of clinical trial data. And so if you are a patient that's on this call and you have the opportunity to be seen at an institution where clinical trials are available, whether that's at a large academic institution, if you have access to that and you're in close proximity to a larger city, or even at a smaller community hospital, where I know many of them, including in my own town, with a robust clinical trial portfolio, those are the places to seek out your care, because you will be given opportunities to perhaps be enrolled in clinical trials that can improve your outcomes, and that what may actually end up developing the new standard of care for how we manage and treat patients. So if you have the opportunity to be considered for clinical trial, and that's something that is of value to you, I strongly encourage patients to seek that out. And like I said, I'm sure my other panelists would agree with the same.
And with respect to finding clinical trials, that's a challenge. Clinicaltrials.gov is a website that lists every single clinical trial that is currently recruiting or will be recruiting, but that website can be very daunting to to patients and caregivers and their loved ones. There's so much information. So what the Kidney Cancer Association has done is with our web team has taken the most important pieces of clinicaltrials.gov. We've sorted it by kidney cancer, the recruiting for kidney cancer diagnoses. And our clinical trial finder lists every single clinical trial that's actively recruiting and pulls the most important information. So the subtype of kidney cancer, the stage of kidney cancer, the inclusion and exclusion criteria. And really tries to make that a little bit more easy to understand, and also where are these trials happening? What's the locations? Like Dr. Bovi was saying, are they at large academic centers? Are they more at regional or community practices and hospitals? And so our clinical trial finder on our website really helps to kind of navigate those trials so that you can then take that information to your doctor and say, hey, is this a trial that's appropriate for me? If not, what are trials that could be appropriate? And just starting that conversation, that dialogue, that you're interested in a clinical trial and that, is one right for you at this time or maybe in the future.
Thank you so much for sharing that great resource, Amy. And I know we have lots of great questions, but unfortunately we are at the 2:30 mark. So that is all the time that we have for today. I want to thank once again our wonderful panelists for taking part in this discussion, for sharing your insights and your knowledge. I want to give a huge thank you for all of you guys for being here.
Thanks for the opportunity, Embry.
Thank you. I also want to thank our webinar sponsor, Genentech, for supporting this webinar. And of course, a huge thank you to the Kidney Cancer Association, Amy, and the entire team there for their partnership and support in putting together this webinar. And finally, a special thank you to each and every one of you who have joined us live today, our attendees. Thank you for joining us and for sharing your wonderful questions. We encourage you to take a few minutes to complete our webinar survey by scanning the QR code on your smartphone or going to the link on the screen there. Your feedback is important to us as we plan for future programs. You'll also be receiving a link to complete this survey along with the webinar recording and our resource handout and a follow-up email message over the next few days. If you're looking for more content like this, please check out our next webinar taking place November 5th on immunotherapy and brain tumors. For more information about ABTA's programs, events, and services, visit ABTA's website at abta.org, email us at info@abta.org, or call the ABTA Care Line at 1-800-886-2282. For more information about the Kidney Cancer Association, please visit their website at kidneycancer.org or call 1-800-544-3522 to speak with a patient liaison. Again, thank you all so much for being with us today. This now concludes our webinar. You may now disconnect and enjoy the rest of your day.
Thank you.